Pinky, who will be one of your next presenters, and I are both members of the Evidence-Based Practice and Research Committee here at East Jefferson. And so you'll see next month nurses and clinicians throughout the hospital present their evidence-based practice projects. So there'll be posters displayed, and we welcome your input into those. And Lisa and I are going to present two of the posters, and Barb are going to present two of the posters that were presented in 2019 showcases. So I'm here today to present the work of the Cath Lab. We have Chris Kruthertz, who's the supervisor of the Cath Lab, and Steve Seiler, one of our Cath Lab techs here. So I'm here to present their work on behalf of the group on preventing acute kidney injury after PCI. As you know, the dye used to visualize the coronary arteries can damage kidney function, especially in high-risk patients. And in 2012, the definition set forth by the Kidney Disease Improving Global Outcomes Guidelines was updated. And so the definition of contrast-induced acute kidney injury is now defined as a rise in creatinine of greater than or equal to 0.3. The incidence of contrast-induced acute kidney injury following coronary angiography and PCI varies from anywhere from 2.8 to 13%. And it's strongly associated with increased mortality, healthcare costs, and progression of renal disease. The pathogenesis of contrast-induced nephropathy involves sustained intrarenal vasoconstriction that can last for hours. And this can result in prolonged contrast time in the kidneys, resulting in cellular death, oxidative stress, and ultimately leading to acute kidney injury. And the impact of this is substantial, increasing the risk of heart disease, long-term dialysis, longer hospitalizations, on average 4 days longer stay, increased hospital 30-day readmissions, and a high risk of death. And as you know, we're taking care of patients in both the acute and outpatient setting. Some of our patients take multiple hits to the kidneys. The risk of contrast-induced AKI increases by an estimated 12% for every 100 milliliters of contrast administered. East Jefferson participates in the American College of Cardiology's National Cardiovascular Data Registry for PCI. So every patient who has a coronary stent here in our facility is entered into this national data registry. This allows us to examine our PCI outcomes each quarter, and very importantly, provides a national benchmark where we can compare our performance against peers and the nation. So this is data from our baseline period. This is the entire year of 2017. And if we look at this metric of PCI risk-adjusted AKI, and this is in the hospital. So you know our length of stay for PCI is rather short. So we're looking at patients who stayed at least 1 day, and they'll be included in this population. The national median, or the 50th percentile, is 5.85%. And in East Jefferson, we were at 8.22. And this put us in the bottom 25th percentile of the nation. Another benefit to participating in the National Registry is the opportunity to attend the National Quality Summit for the American College of Cardiology. And their organizations share success stories and strategies they've used to improve patient outcomes. In 2018, with support of a Donna Schwartzbeger scholarship, I was able to attend the summit in Orlando and network with other institutions who had implemented strategies to reduce acute kidney injury. So I brought that information back and some poster session information, met with the cardiovascular leadership team, and they committed to do an equality improvement initiative related to this important metric. As we started out with our scientific inquiry, we were guided by this PICO question. In patients undergoing percutaneous coronary intervention, is communication of safe IV contrast limits based on individual renal function an effective strategy to reduce the risk of acute kidney injury? We reviewed the published literature and evaluated the strength of the evidence, and these are some of the selected sources of evidence that I'll present. One source of synthesized evidence that was recently then published, right, coinciding actually with our initial efforts, was a toolkit on the subject of preventing contrast-induced acute kidney injury by SCI, the Society for Cardiovascular Angiography and Interventions. We also reviewed relevant societal guidelines, these published in circulation by the American College of Cardiology, American Heart Association, and SCI in 2011. And the recommendations in summary, the only strategies clearly shown to reduce AKI are hydration and minimizing the amount of contrast dye. With Class 1 recommendations, patients should be assessed for the risk of contrast-induced AKI before the PCI procedure. Patients undergoing cardiac cath with contrast media should be adequately hydrated, and patients with chronic kidney disease with a creatinine clearance less than 60, the volume of contrast should be minimized. Oops, what did I do? There we go. This is some data from a large-scale observational study. It included over 58,000 PCI patients. And it set out to look at renal function-based contrast dosing to define what safe limits of contrast for PCI would be. And as you can see here from the data, the conclusion was that contrast-induced nephropathy increased when the contrast volume to calculated creatinine clearance ratio exceeded 2, and even more significantly when that ratio exceeded 3. And the recommendations from that study, and this was again a well-designed, large-scale observational study. It originated by the University of Michigan in a statewide Michigan Blue Cross collaborative, so a large volume of patients in many different institutions. The contrast dose on the basis of calculated creatinine clearance using the Cockcroft-Gault equation with a planned contrast restricted to less than 2 times the calculated creatinine clearance and not to exceed 3 times the creatinine clearance might be valuable in reducing the risk of CIN and nephropathy requiring dialysis. And the contrast thresholds based on that ratio should be stated during a timeout and the operator notified by the staff when the ratio is approached or exceeded. During the pilot, as we implemented and did some small tests of change, we found that the calculated creatinine clearance in large patients, those patients over 90 kilograms, who you have met here, right, at East Jefferson, yielded large contrast volume thresholds. So, for example, a patient weighing 110 kilograms might have had a threshold of 381 cc's, and we would all shake our heads saying, that's too much, right? And other centers that we had interacted with reported using GFR. So we asked another question, does the evidence support using estimated GFR instead of calculated creatinine clearance? And this is a comparison of those two formulas, which probably a lot of you are aware of, but the Cockcroft-Gault equation uses weight as a variable, so that's where we were getting our large mass patients, we're getting a larger number. EJ Lab for the GFR uses the MDRD study equation, and it uses a constant to normalize for weight. And so there is going to be less variability across weight ranges for that. This is just a drill down of some of the data from that large observational study looking at safe contrast limits. And this is the calculated creatinine clearance, where you see over 3 a dramatic increase in both contrast-induced nephropathy and AKI requiring dialysis. If we look at that same data using GFR, this was published in some supplementary data for the study. We can see that the results are mirrored using GFR. So we also sought the opinion of the lead author, Hatinder Gurm is his name. And around the country, people call this the Gurm formula. So he's kind of the pioneer of this field. So when I spoke to him on the telephone, I had noticed he had been publishing case examples and talking about GFR. we had a conversation about using GFR instead of creatinine clearance. And his advice was use what's most accessible to the cath lab staff. And he assured me that the GFR is actually what they're using at the University of Michigan and most Michigan hospitals out of that Blue Cross collaborative. And they've published it as a best practice guideline in the state of Michigan. So the practical benefits of switching to GFR it was a more clinically relevant threshold for our large patients. It also saved the cath lab time. The nurses were using a PowerPoint calculator to calculate the creatinine clearance using the Cockcroft-Gault equation. And so they could just simply use the GFR from our lab values. And so that really helped for us all to be on the same page with risk assessment. So patients with a GFR less than 60 are at higher risk. So here we have patients with GFR, you can see their incidence of contrast-induced nephropathy at that threshold of GFR are at substantial risk. Then we really were, I thought that the biggest impact would be a cultural shift. So many people in the cath lab team were using creatinine as an index of renal function as the patient arrived to the cath lab. But as you know, GFR is really a better indicator. So this is exemplified here. Each one of these patients has a serum creatinine of 1.2. But the 22-year-old black man comes up with a GFR of 98. The 58-year-old white man, same creatinine, but his GFR is 66. And the 80-year-old white woman with a GFR of 46. So our approach to contrast for those different cases would be quite different, right? So this is the practice change that we decided based on that evidence that we would implement. The contrast volume, the GFR ratio, should be kept less than 3 and ideally less than 2. And the limits should be stated during the timeout and the operator notified. So we did education of all the staff. And so if the patient's GFR is 50, we're going to say, hey, ideally use less than 100 cc's. And definitely we want to try to keep less than 150 cc's. So a pretty simple calculation. So we implemented the practice change, and this is a copy of the green sign, and Chris has copies of it over there too. The cath lab nurse in the pre-procedural area will make the sign based on the patient's contrast limits and GFR. So they write the GFR, everybody in the cath lab is going to know their GFR, what the recommended limit and the upper limit would be. In the comment section of our lab, if you click on that comment tab, there's an important modifier here for African Americans. You need to multiply the lab value times 1.21. So that's on the sign for the cath lab nurses to do as well in the case of an African American patient. And so here's back to our patients who all come in with a creatinine 1.2. But this gentleman's contrast, 2 times his ideal contrast would be limited to 196. For the 58-year-old white man, 132. And for our 80-year-old woman with a GFR of 46, we want to plan a procedure with 92 cc's of contrast. And this is a picture of the cath lab. We have a huge monitor that the physician and the team are using during the procedure. And they hang this right there on the monitor so that the entire team is focused. We know it's not just the physician, it's the entire team who works together to achieve those limits. We also added some acute kidney injury risk factors to our pre-procedural check-in. So the nurse looks at the labs, writes that GFR here. Does the patient have any peri-procedural hypovolemia? And how much of that IV pad that was hung prior to arrival to the cath lab is gone? Did that patient get the adequate hydration? Well, that's a whole nother day, but we are working on hydration protocols. Does the patient have diabetes or heart failure or anemia? Those are also additional risk factors that should be communicated to the physician and the team pre-procedurally. These are some recommended practical methods of lowering contrast volume using echo in lieu of left ventriculography. So that LV Graham takes 30 cc's of contrast in a standard procedure, limiting the number of injections, 5 French catheters, and biplane imaging IVUS, and considering staged procedures. So we had some superstar physicians who embraced this and along with the Cath lab team strategized. Here's a great example. So this patient came in, they had a history of a CABG and a PCI, diabetic, PAD, 127 kilograms, creatinine 2, GFR of 33. They presented with a stuttering MI, having an acute non-STEMI. As they went to the Cath lab, there was difficulty accessing the patient's artery. Angio was performed with a 99% RCA correlating to the subtle inferior wall changes on their EKG. Brief but reasonable attempts were made to enter the left coronary system to finish the angiogram, but they were unable to enter. And due to a creatinine of 2 and a GFR of 33, the physician documented their intent to limit contrast exposure. They did a single vessel PCI to the proximal right and stopped the procedure. So the patient's pre-GFR, was 33, and the contrast volume used was 34 cc's, so that contrast volume to GFR ratio was 1. So we were well within our limits of the recommendation of 2, right? And their creatinine went from 2 to 1.9 after the procedure, and then on follow-up post-discharge was at 1.6. So a really great example of a very low contrast use in a high-risk patient. These are our overall outcomes. This is really the good stuff. The blue bars represent before. So you can see 2017 and the beginning of 2018 before the practice change. We were, up in here in the 8, 9, 10% of our patients having acute kidney injury. And then after the practice changes, 3%, 1.2, and 3.9. This was observed acute kidney injury with a rise prior to hospital discharge greater than 0.3. That definition used to be 0.5, but was updated in 2012 to 0.3, so it's a pretty narrow window. This is the National Registry data, and so it is risk adjusted. So risk-adjusted acute kidney injury after PCI is the national metric. The baseline rolling 4 quarters prior to intervention, we were at 9.53% overall. And each of these groups, these rolling 4 quarters, represents over 400 patients here. So a large group of patients at each Jefferson. The 4 rolling quarters after our intervention, we were down to 3.2. And so we went from the 10th to 25th percentile in the nation to being in the 90th percentile in the nation, outperforming 90% of the organizations. So that was a great success. And one of our cardiologists, just acknowledging the important cultural shift and saying, knowing the contrast thresholds before the case begins helps me to better plan the procedure. So we knew that it was a true team effort, as evidenced by that. I really want to thank the Cath lab team. Again, Chris Pruthertz, who was a nurse when we started the project, and now serves as the Cath lab supervisor, and Steve Seiler, who has some great personal stories about his own siblings and acute kidney injury that motivated him to be a real asset for this project as well. And I really want to thank Dr. Gregory Tilton, who was the chair of the Cardiac Cath Lab Committee and one of our physician champions, and Dr. Gary Menzer, who serves as our long-term division chief of cardiology, and all they contributed. I'm going to go back to this slide with the data, because I don't know if y'all caught it, because I was touting our success. But look what happens over here in 2019 and the beginning of 2020. So we have a little blip up here. And as I was reminded, the ACC Quality Summit took place virtually just last week. And as one of the cardiology speakers said, that sustaining the change is at least 2 times harder than making the initial change, right? So we all know that from quality improvement efforts. So we're going to be back to the drawing board, re-looking at some things. As I said, we're working on hydration, we're working on drilling down on our data and examining it and trying to be sure that we're sustaining these practice changes and that new staff are integrated into this. So we do have some other great examples where we really limited the procedures. I've definitely seen in the registry, as I look at each of those patients, a lot more staged procedures. You know, there's this tendency with multi-vessel disease, get them in, let's go ahead and fix everything. But we definitely are seeing more patients brought back in for a second procedure, giving them time for their kidneys to recover, and a planned approach to that. We've also had some ultra-low cases where we did an angiogram using 11 cc's. Of course, this takes a big commitment from the physician in changing techniques, because that's not the way we've always done it, right? This is some of our sources of evidence, and if you're interested in this topic and would like more information, there's a contact hour presentation for CME and CME. You can go to Cardiovascular Learning Network and search kidney, and there's free contact hours and lots more information on this topic. Does anybody have any questions for me or for our Cath Lab team? Thank you so much.
Thank you all very much. Just one little caveat before we start our next presentation. If you do want CME credit for this, please make sure you sign in for me. Otherwise, I can't guess who's here and who is not. Some of you have, so I appreciate that. But if you are staying forward for CME credit, please make sure you sign, print your name on the sign-in sheet. We appreciate that. All right, our last presentation for today. We appreciate having them with us today, Ms. Lisa Hickey and Ms. Barbara Carson from Women and Newborn Services. They will be speaking on what are the evidence-based pain management